Thank you very much. It's a privilege to be here. And my talks will be back to back. I wanted to give sort of one serious talk and one fun talk. You'll enjoy the second one. It is strabismus. Most people get turned off by strabismus when they're in general ophthalmology, but it's a fun talk. So at first, I'm going to talk mostly on what I do now for pediatric cataracts, but I do want to, as I'm doing that, talk about how we apply these same principles to developing world and building capacity in the developing world. Here are my disclosures. I put this up because I think that with adult mission work and developing world capacity building, the adult world has been so far ahead of trying to reach kids, the challenges of general anesthesia, of trying to find folks that really are interested in operating on children and all the extra demands. Our American Association for Pediatric Ophthalmology and Strabismus just created a humanitarian award. It's not so important that they gave me the inaugural award. There'll be many more recognized folks as the years go by, but what I like is that in the letter there they create this award to recognize capacity building and unity and the trying to link the pediatric ophthalmology world. That's more important than just going into the field and doing a few cases, but going into the field and helping them get capacity, get equipment, get a system set up, train the anesthesiologist, do everything that then makes it possible for you not to have to go back. That's what's important, and that's what we need in pediatrics. This was just a visit earlier this year in Nepal. Went back and very gratifying to see that the people I trained have just made huge strides, and I was able to do some surgery there just a couple of months ago. I mention this because pediatric cataract surgery cost per case is higher because of anesthesia, because we are a little more dependent in the pediatric world to having them buy some machinery. The Ertley machine you have out there is a wonderful developing world machine. So the cost per case is higher, but the number of blind years that you can create, that you can save, makes it the most cost-effective procedure in all of ophthalmology. Every time you find a blind child and you restore vision enough for that child to be independent, 50, 60 or more blind years prevented. And that's why it's so cost-effective. The World Health Organization, this action plan from years ago is still behind. It is still not being realized. It doesn't sound that audacious. I mean, train one pediatric-oriented ophthalmologist for every 10 million population, but we're still behind. And as much as I congratulate every adult ophthalmologist for being able to take a microscope in a truck, go out and clean up a school room and do 100 cataracts a day, the pediatric blind kids right outside the door are still not being taken care of. You're used to this. I love going to these trips after I've done my anesthesia cases. I usually just watch and marvel at the speed that these adult cases can be done. That's what you're used to. What I try to emphasize is at the same time, right outside in the courtyard and nearby in the villages, the kids are there, their moms are there, they need to be screened. While you're doing the adult missions, screen the kids, find the kids, and arrange for transportation so they can get back to a center that offers anesthesia. They're out there. These are my pictures, just kids that are just roaming around the adult mission. And nobody sometimes is taking care of them. Capacity building means a lot of things. This is also in Nepal, where they make their own intraocular lenses. So there's a lot that has to do with capacity building in adults that we also utilize in kids. And here again, some Nepal pictures that I like to throw in there. This is one of my nurse anesthetists teaching anesthesia. We can't leave that to chance. And some of the places where I visit, what has stopped sometimes their pediatric program in its tracks is a death of a child under anesthesia because of poor airway management. Something you don't think about when you're out there doing your mission work. But we have to think about it, and we have to actually jump in there and start training them, because there's not anybody else that's going to train and help keep that up. The other big problem is they have one anesthesiologist and they have one general anesthesia table. And every time you get a schedule of pediatric cases, a ruptured globe comes in and it takes precedence, and the GA table is booked for the whole day with trauma, and you can't get the kids with the cataracts in. So they need more than one table every so often that offers the general anesthesia. I just put this up because on the wall at the Telganga Eye Institute in Nepal, the most cited papers over the years, our paper is number 2 that talks about pediatric cataracts in the developing world. I think we have one down there at number 9 also. Now, another center that when I first started, Albert Henning started this Lahan center right near northern India border, and needed some capacity, needed a machine. I actually was one of the first places where I got the Ertley machine into him to really modernize the cataract surgery. Now he's turned it over to the locals when he retired in 2012. This is the highest volume pediatric cataract surgery I have ever seen, and I've been almost everywhere in the world. Now, you think that's pretty impressive numbers. They had a little dip at COVID, you know, that's what everybody did, but now they're back up. But their adult cataract volume in 2023 was 86,875. So they're doing an incredible volume of pediatric cataracts, but the adult to cataract ratio is about 62 to 1. I've always said as an estimate that the goal of every adult high-volume cataract center in the developing world, they should find one blind child for every 50 adult cataracts they operate. This turns out to be not that far off, because it's 62 to 1. So that seems like a small number, but you know, when you could do 86,000 adult cataracts, that's great. Those folks are going to live 5 to 10 years. These kids in these bars are going to live 60 or 70 years with your result. And here's our operating room, and I wanted to sort of talk about how we approach our cataracts now at MUSC in Charleston, and how we teach our fellows, and a little bit of my bias for how I think things should be done. And this does relate to the developing world with some caveats. Now, I'm going to talk about 3 groups, the blue, the yellow, and the green, as these age groups. This is a relative frequency of pediatric cataract surgery ages. This is something that I always try to keep in mind when I travel. The best possible operation is not necessarily the best operation possible. Now, you know that from adult surgery. You know what the best possible operation is. So if you've got a perfect microscope, you've got every machine in the books, you can get your capsule tension rings, you can get anything you want, you know what the best possible operation is. If you're somewhere else and your goal is a good outcome, remember that the best possible operation may not necessarily be the best operation possible. And trying to decide when you can bring in equipment and when you can't, and when you should do a much more manual, a much more an operation that doesn't require a great microscope with a good red reflex view. And always keeping that in mind, because we want to do the best possible operation everywhere. and that's not appropriate in some places. Okay, with that in mind. Now, for us, the infant aphakia treatment study, which I was a big part of, and other studies have indicated that the best outcome for us in the developed world in the first 7 months of life is to leave the child aphakic. This is what that talks about. So my go-to operation with the goal to restore vision with the least amount of surgical trauma and the least amount of postoperative inflammation is this: 25 gauge vitrector, an irrigating cannula, bimanual surgery, a vitrectorexis on the anterior capsule, aspirate the lens with the cutter turned off, take the plaque in the posterior capsule, do an anterior vitrectomy, 1 time in, 1 time out, tenovicryl on the wounds. It's very fast. Contact lens. This is a silicone elastomer contact lens at the end of the surgery, and that creates very little inflammation, especially if you do it carefully. And so this 5-week-old eye, this is what they look like on day 1. No patch, no shield. Child can start seeing right away. Hand them back to mom. Now, I will put an IOL in this eye, but it'll be later, usually at preschool or 4 or 5 years of age. This is the lens we use. I stock them in the operating room. I do it all myself. I don't need a contact lens service. I put a 7.5 base curve on all infants, transition them to a 7.7 base curve later on as the cornea naturally flattens. And we created a lens constant for the Silsoft. One doesn't exist, so we created it. 111.9, I put that into my IOL formula. It tells me exactly what contact lens to put on the eye initially. So I just treat it as though it were another IOL. Now, in the developing world, or even in South Carolina, which I call a developing state, if a contact lens is just not going to work, what I've been teaching since the 1990s in the developing world, back when we only had very stiff PMMA lenses, was to still get a cutter, still do the 1 time in, 1 time out. This happens to be a very sort of calcific lens, but we recommended an intraocular lens. Even if it was too big for the small capsular bag, we recommended putting the lens in the sulcus and doing a bicapsular capture. Now, with kids, the lens epithelial cells are very active. Even if you clean the bag as best you can, they're very, very active, and so they're going to produce new lens cortex, and that's going to get out into the pupil space. So with aphakia, your anterior rexus, posterior rexus are the same size. It seals, and everything gets trapped, and you can take it out later as a sombering ring. In this case, I have to let the capsular bag seal, and so I put the lens in the sulcus, and then I capture, bicapsular capture, with this happens to be a 3-piece IOL. I don't have to worry about whether the entire lens will fit into that small capsule, and that was a 6-week-old surgery there. Now, what I've been doing more and more is I've been doing no-drop cataract surgery in kids for years. We got a hold of these devices, like this is the Dextenza. It's a slow-release depot of dexamethasone. I use intracameral antibiotics and no post-op antibiotics. There's no literature I can find that shows proof that post-op antibiotics do anything. Put them in the anterior chamber where they belong, and then that's it. And then I use the Dextenza as my steroid. And then I only supplement if it needs it. And I still use aphakic glasses. Now, this is a placeholder until an IOL, but don't think that in modern surgery there's no place for aphakic spectacles. They work wonderfully. So since we're leaving a lot of kids aphakic, we are presented with a lot of secondary IOLs. And we've been trying our best to popularize the concept that secondary IOLs after the child's been left aphakic in infancy should be in the capsular bag. And usually, 90% of the time, that's where I put it. The earlier you do the surgery, the more, even with good irrigation and aspiration, those lens epithelial cells produce new cortex, and you end up with a sombering ring. That actually holds the space open for you. So then you can either use scissors or a blade. I use the 25 gauge vitrector. I open that sombering ring all the way around, get rid of all of that cortical space, and then my implant is in the capsular bag, and you can use your favorite in the bag lens. You don't have to go to a lens that's appropriate for the sulcus. And this is a little more work, but you can do it without tearing up the capsular bag. And that's the way, and if we plan on that at our original surgery, we plan that this will be the eventual. I like to do surgery knowing that I'm going to be back in that eye in a few years. If you do the surgery and you figure, I'm not going back into that eye, then you may just want to, take all the capsule you can reach and then let somebody else worry about sewing in a lens or doing something else. Now, there are a few cases, especially if the surgery was done a little later in infancy, where there's not much sombering ring. Now, what I like to do is peel the two capsules apart and use visco dissection to blow some OVD all the way around and open up that space. But it's perfectly appropriate. This was one I just showed where I decided it wasn't worth it, and I just put a lens in the sulcus. That's okay. A lens in the sulcus, if it needs to be exchanged when they're 20 because you didn't anticipate growth well enough, much easier to exchange. So there's some pluses and minuses. One of the things I've discovered is the Rayner lens comes preloaded. The Rayner lens is a hydrophilic acrylic, and it has a particular design that makes it appropriate for the sulcus. It's the only single piece lens I'll ever put in the sulcus, but it actually works great in the sulcus. And that's a pearl you can use even in adults. Because I don't like three-piece lenses. They kink, they're too small. They move around in the sulcus, and you have to optic capture them or they're not worth using. So now if I move to that yellow group, now this is my go-to if I have a good microscope, not necessarily in the developing world, but so in this group, we're starting now in year 1 all the way up to maybe year 7 or 8. Manual capsulorhexis. Irrigation aspiration of the cortex and pars plana, posterior capsulectomy after the lens is already in place. I like this. I teach my fellows how to do this because I like to put the lens into a soft pediatric eye while the posterior capsule is still intact, get it situated, take all the OVD out, and then in a controlled manner, I can cut the posterior capsule wider than I would dare cut it if I was doing it from the front, and you never drag vitreous out to your wound. But sometimes we do it a different way. This is the most common way that it's done in the developing world, and I think it's by far the most common way that it would be done by an adult cataract surgeon. And that is to avoid at all costs the vitrectomy. I like vitrectomy. I don't think vitrectomy causes retinal attachment. Traction causes retinal attachment. So in this instance, and we'd still do a lot of these, this is manual capsulorhexis, again, irrigation aspiration. But what I'm going to do is do a manual posterior capsulorhexis, push the vitreous face back with some OVD, and then leave where you've got the posterior capsule so that you don't need to try and chase this child around the YAG laser. Now, you notice I'm doing the cortex in the periphery first, Kids have very soft sclera. Very soft sclera creates scleral collapse. Scleral collapse pushes the formed vitreous upward. That vitreous upthrust is what is sometimes called posterior vitreous pressure. It's not posterior vitreous pressure. It's just vitreous upthrust. So your posterior capsule keeps wanting to come up in your way. So what I do, since there's no need for phaco, is I leave the center of the lens till last because it holds the posterior capsule out of the way, irrigate the periphery first, and then do the center. When you do a manual posterior capsulorhexis, and I know you probably do a lot more of these than me, but OVD goes on top of the anterior capsule, not in the back. You don't want to bow the posterior capsule back. You want to flatten the anterior capsule on top of the posterior capsule and put very little in the middle so that your posterior capsule is still flat or maybe a little bit convex. Then you make a little glancing blow with a blade. I just use an MVR blade. And then you separate, you create some separation between the anterior hyaloid face and the posterior capsule. I use a dispersive OVD because I can leave that in the eye. I don't like to leave cohesive OVD in the eye, but a dispersive I will. So I make sure that I've separated, I've created that space, and if you've got an OCT on your microscope, which we do, you can see the separation. You can see where the posterior vitreous face is, and especially in kids, the posterior vitreous face is very easy to see. It looks like another posterior capsule. So here then, once I get that separation, I'll tear the posterior capsule, and then in this instance, put the lens in and capture. This is the lenses in the bag, and I do posterior optic capture and no vitrectomy. Now this works, a lot of people in the developing world think it works all the time, but they don't necessarily follow the kids very long. If you try to do this when the child's a little bit too young, then you can still get opacification, even with optic capture. And this all I'm going to do is just capture the optic here. All right, here's an example. Here's a nice optic capture, no vitrectomy, looks good, sort of. Patient's complaining, he's a little older now. Shine the light right. That's what the vitreous face looks like. So I still have a bias toward my pars plana vitrectomies because of this sort of thing, and that can't be yagged. So you have to go in pars plana and clean that up. So you can get, even with optic capture, you can get opacification of the vitreous face in children. I've never seen this happen in adults. Now in the third category, yes, leave the posterior capsule intact in these older kids. But my bias is still, YAG laser's hard. I get a lot of these referrals where the PCO has gotten too thick and the YAG fails. Then I have to go back and clean it up. You got to do it early if you're going to do it. Or successful YAG laser in a 13-year-old and all this junk because of the formed vitreous just stays in the way and you got all these floaters. Still have to go back and clean it up. And then it makes me wish that I'd taken 5 or 10 more minutes and done the posterior capsule at the very beginning. So those mean that I think about this even in older kids. Toric IOLs are wonderful in kids, but the elephant in the room is cost. The companies won't give many lenses because it's off-label. They can't promote off-label. The parents don't want to pay for it because you still get a myopic shift with growth. But there's nothing wrong with it. The Ks in kids are pretty stable after about age 4, but still, it's a problem. Not all new IOLs are multifocal. I like the newer monofocal lenses that I don't have to throw an upcharge to these young families. So this is an iHance. I like they have a better defocus curve. So in kids, we're looking at this too. One of the things we use constantly is we've created a regression formula to individualize. We can predict axial growth in an individual child, And so I do this formula. We now have it in an app. Do the formula. I can predict the axial length at age 20, and I can aim my IOL and put that new axial length into the formula. Last thing, physician-administered medicines. I mentioned that a minute ago. Parental compliance. Gosh, you know, parents do the best they can. But the variability in healing is directly related to the variability in the parental compliance. Very early on, we went to these sustained release steroids and intracameral antibiotics with no post-op drops. So that, I think, is the way to go when you can. This, again, is just at the end of the case, punctum dilator, put the Dextenza in the punctum. It fits even in an infant eye. And this we've reported I now have many, many more cases, but we have reported off-label use. And here's safety data on pediatric moxifloxacin in the anterior chamber as an intracameral. And a special thanks to Rupal Trivedi, who's my research associate. She's been with me for over 20 years, and we've published a lot together. So thank you. Kirk has one on there. Yeah.
Do you make with the view to separating the anterior and posterior leaflets, do you make your anterior posterior rexus larger or smaller than each other?
Try to match them.
Okay.
I want them to seal. So you do get a white ring. You get a little bit of a fibrosis. If one's bigger than the other, then you might go through both, or you might go through it. So I like to try and match them. Then you get this white ring. Now, if it phimoses a little bit, I leave the white ring until the very end. So I don't mind removing that white ring, but after I've already opened the bag, gotten all the stuff out, gotten the lens in place. You see, so then if you say, gosh, that's almost in the visual axis, remove it after everything, because the white ring is very stable. So once you open the ring, that white ring is fibrosed, so it's not going to break on you. But if you remove the white ring, then you can get a radial tear.
Ed, great talk. I've got a quick question. On those children that you don't put an implant in initially, and you put a silicone contact lens in, are you shooting for emmetropia? Are you shooting for a little bit of myopia, knowing that their world is close up? What are you shooting for?
Ideal is -2. So you aim for their world's at near, you aim for that. The super plus lenses from +32 down to +20 only come in 3-unit steps. So I try to overpower it. So when you got a 32 in there, the next lens is a 29. So I don't change it until they're maybe -3, -4, sometimes -4. All they need to do is focus on mom's face.
Yeah, I'd just like to make a comment. I'm Dan Graydon. I do trips with Samaritan's Purse and worked for about 10 years in Nairobi. And we now have a portable vitrector made by Jason Leng called the V-Cube, and it's very cost effective for managing the capsule in children on outreaches.
Yeah, no, that's great. Yeah, that's great. It just needs to be a high enough cut rate. Safety is directly related to the speed of the cutter, because you don't want drag cut. You get a lot of traction that way. So it needs to be at least 800. I mean, I'm using 15,000 to 20,000 cuts per minute, but I wouldn't trust anything that's below 800 cuts a minute, just because of the traction that it creates.